So good morning everyone. In the previous class, like we have discussed about the inflammatory, autoimmune, obstructive disorders of the salivary gland. So today's class is about the benign and malignant tumors of the salivary gland. First we are going to talk about pleomorphic adenoma, which is a benign tumor affecting the salivary gland. So it is the most common tumor of all the salivary glands, both in children and in adults. And 2/3 of the parotid tumors and 50% of all the salivary gland tumors are pleomorphic adenomas. The most commonly encountered site is the superficial parotid gland and often the tail of the gland at the angle of the jaw. On physical examination, this tumor tends to present as a firm nodule reflecting the abundance of chondromyxoid matrix. So it's a benign mixed tumor because of its dual origin from the epithelial and myoepithelial elements. And studies have shown the etiology as the exposure of radiation. In the sense, the exposure to harmful radiation is a predisposing risk factor for the development of this tumor. And almost 45 to 75% of all the salivary gland tumors are pleomorphic adenomas, and it is most commonly seen in 3rd to 6th decade of life, and it is slight female predilection than in the males. So when you talk about the pathophysiology, microscopically it has a high variable appearance, hence the name pleomorphic adenoma. So on a histological slide, it presents as a mixed proliferation of polygonal epithelial and spindle shaped myoepithelial cells which are embedded in a variable stroma matrix. The tumor lacks a true capsule and is surrounded by a fibrous pseudocapsule of various thickness, and it has also got microscopic extensions. That's why there is a high risk of recurrence in cases treated with simple enucleation or surgical resections performed with inadequate surgical margins. To justify the recurrence of the pleomorphic adenoma, the main two reasons are: one is the microscopic extensions, and the tumor itself lacks a true capsule, and it's a mixed proliferation of polygonal epithelial and spindle shaped cells. So on clinical presentation, it is seen as a solitary, mobile, slow growing, painless mass which may be present for many years. The symptoms and signs usually depend upon the size of the tumor, anatomical location, and its potential to undergo malignant transformation. And since we know that the facial nerve is traversing the parotid gland, when the tumor is involving the parotid gland, there can be signs of facial nerve weakness when the tumor is large or if it is undergoing a malignant transformation. Pleomorphic adenoma in the deep lobe of parotid gland may present as a oral, retrotonsillar or parapharyngeal mass which is visible or which is clinically palpable. However, the minor salivary glands, since the minor salivary glands are distributed over the pharynx mucosa, they can cause variable symptoms like dysphagia, that is difficulty in swallowing, hoarseness of voice, dyspnea, difficulty in chewing, and epistaxis depending upon the site of the tumor. So the diagnosis is made by confirming both on tissue sampling and the radiographic studies. Two kinds of tissue sampling procedures are usually followed. One is your fine needle aspiration cytology and core needle biopsy. And you can also take help of immunohistochemistry and CT examination of a pleomorphic adenoma. It usually presents as a smoothly marginated or lobulated homogeneous soft mass, and necrosis can be seen when the tumor is large enough. Few foci of calcification can also be seen. This tumor on an MRI scan, it presents as smaller masses with a well circumscribed and homogeneous lesion, whereas large tumor appear as heterogeneous lesions. So what could be the possible differential diagnosis? First is your Warthin's tumor, then the parotid nodal metastasis, secondary to other tumor involvement, facial nerve stranomas, myoepitheliomas, mucoepidermoid and adenoid cystic carcinoma. So to confirm, histopathology remains the gold standard in differentiating the tumor. The second tumor is the most common malignant tumor affecting the salivary glands is your mucoepidermoid carcinoma. While the pleomorphic adenoma, that is a benign variant of the salivary gland tumor, is affecting the parotid gland, mucoepidermoid carcinoma is usually seen affecting the minor salivary glands. So it comprises of about 5% of all the head and neck malignancies. Minor salivary gland tumors account for about 10 to 15% of all the salivary gland neoplasms and are usually malignant. The second most common minor salivary gland tumor, that is, it is affecting about 12 to 40% globally, and it is more frequently seen in females, occurs in the 5th decade of life, and usually found in the parotid gland. However, palate is a frequent site when it occurs in the minor salivary glands. So clinically, the tumor may be seen as a mass as seen in this picture, and in this region the minor salivary glands are affected. So how do you manage a case? So the treatment of choice is a superficial parotidectomy or total parotidectomy. So before understanding the surgical procedure, we need to understand the anatomical landmarks. As you can see, the parotid gland, it is bounded anteriorly by the masseter muscle, posteriorly by the sternocleidomastoid muscle, and the duct of the parotid gland pierces to the buccinator muscle and opens into the buccal mucosa at the level of upper second molar. And superiorly it is guarded by the zygomatic arch. The facial nerve, as you can see in this diagram, it is giving off branches in the substance of the parotid. Therefore, careful attention has to be given while dissecting the gland while surgical excision of the tumor or parotidectomy. Otherwise, injury to the facial nerve can lead to a complication called as Bell's palsy. So this is a surgical procedure showing the marking of the incision, surgical exposure and the deflection of the flap and identifying the tumor mass. So this is a clinical case where the patient is presenting with a classic nodule kind of appearance beneath the ear and in front of the ear, which is most commonly suggestive of pleomorphic adenoma. And this is an axial CT image suggesting a tumor. So this is a gross specimen of the tumor when it is excised. So what could be the possible complications associated with this surgery of the salivary gland, either for the benign pathology or the malignant pathology? Let's discuss few of the complications. So the complications can be categorized as intraoperative complications, the complications and postoperative complications. So again, they can be further classified as early complications and late complications. Transection of facial nerve, rupture of the capsule of the parotid tumor, incomplete surgical resection of the parotid tumor causing recurrence is commonly seen intraoperative complication. Whereas under your postoperative complication, symptoms which are seen early are categorized as early complications and symptoms those present late are classified as late complication. So facial nerve paralysis, hemorrhage, hematoma, infection, skin flap necrosis, cosmetic deformity, trismus and parotid fistula come under the early complications, whereas the late complications include facial synciness after facial palsy, which is a cosmetic defect, hyperesthesia of the greater auricular nerve, recurrent tumor, soft tissue deficit, hypertrophic scar or keloid, and Frey syndrome. So Frey syndrome, what is Frey syndrome? Frey syndrome is also called as auriculotemporal nerve syndrome. It is most commonly seen in 60% of all the parotidectomy cases as an untoward sequelae. It causes discomfort and localized facial sweating and flushing during mastication. That is, when the patient is having the food, he experiences discomfort and localized facial sweating, also called as gustatory sweating. So this is because of the parasympathetic and sympathetic secretomotor stimuli are misdirected to cholinergic receptors of these sweat glands during healing after the parotid surgery. There is no effective treatment as such, but various conservative measures can be suggested, like injection of a botulinum toxin, surgical transection of the nerve fibers, and application of an ointment containing anticholinergic drugs such as scopolamine. The next is the cosmetic deformity, which is seen as a post-surgical defect. Most commonly associated defect is your incision mark, and it gives a sunken cheek appearance due to the loss of parotid gland and the fat. And the rotation of the sternocleidomastoid muscle flap at the time of surgery and free flaps also cause considerable cosmetic deformity. So in this picture you can appreciate the sunken cheek appearance or hollowness on the cheek as a sequelae of parotidectomy. The next important complication is hematoma. This is due to the inadequate hemostasis before closure. Suction drains reduce the possibility of postoperative hematoma. This can be managed by either by evacuation of the hematoma, control of the bleeding points by cautery, or reinsertion of a suction drain and closure. The next complication, a major complication, is facial palsy, and sometimes it can be permanent due to the transection or cautery injury to the main trunk of the facial nerve. As I mentioned earlier, the facial nerve travels to the substance of the parotid and gives off branches. Therefore, care should be taken while dissecting the parotid gland. It is always suggestible to identify the facial nerve branches and proceed with the dissection to avoid injury to the facial nerve trunk. The incidence of the permanent facial nerve injury is generally reported as 0 to 5%. So this patient here is presenting with the classic symptoms of the facial palsy. The next complication is your salivary fistula. This presents after suture removal at the suture line and posterior to the ear lobule following parotidectomy surgeries. It can be successfully managed by pressure dressing, drains, anticholinergic drugs to reduce the salivary secretion. So to conclude, the complications associated with salivary gland surgery cause considerable discomfort to the patient. Therefore, intraoperative or preoperative facial nerve monitoring is always advisable, and the surgical technique should be devised in such a way as to avoid the injury to the facial nerve while dissecting. Thank you.